lumbar disc disease, a prospective randomized control study. The ultimate aim of fusion surgery is to stabilize the motion segment, restoration of disc height and foraminal height, decompression of central canal, and the lateral recess decompression. Central canal decompression can be achieved by both direct and indirect decompression, among which MIS-TLIF and OLIF are indirect decompression methods. MIS-TLIF and OLIF has its own pros and cons. MIS-TLIF is technically easy, all levels are accessible. The single position surgery, however, there is a risk of root and dura injury. On the other hand, OLIF, a large case can be inserted, better lordosis is restored. However, it needs change in position, it has a longer learning curve, and L5S1 level is sometimes not accessible. Hence, we do a modified OLIF procedure where we insert OLIF and put anterolateral screws in the same position in a single sitting. The aim of our study is to analyze the indirect decompression effects of spinal canal in MIS-TLIF versus OLIF in degenerative lumbar disc disease. This is a randomized control study where every odd patients were assigned MIS-TLIF and even patients were assigned as OLIF. It was conducted in Ramchandra Institute with a sample size of 40. All single-level degenerative lumbar canal stenosis with instability was included in our study. Once surgery was done, the clinical assessment was done with VAS score and ODI score immediate post-op, as well as the radiological assessment was done with disc height, foraminal height, and segmental lordosis. And at 1 year follow-up, the clinical outcome was reassessed and MRI was done for all the patients to assess the ligament thickness and area, and as well as the central spinal canal area. Coming to the results, OLIF had a shorter surgical duration as well as and the average blood loss was less in OLIF compared to that of MIS-TLIF. Coming to the functional outcome, the VAS score of leg and back significantly improved in both the study population. However, at immediate post-op, the VAS score of back was a bit higher in MIS-TLIF. However, on final follow-up, the VAS score of back was similar in both OLIF as well as MIS-TLIF. On radiographic evaluation, there was better restoration of disc height as well as foraminal height in OLIF compared to that of MIS-TLIF. On MRI evaluation, there was significant increase in the spinal canal area as well as decrease in ligament thickness as well as its area in both MIS-TLIF and OLIF. Coming to discussion, this is a paper discussing about the indirect effects of OLIF, where they say that the early effects are due to stretching of annulus and ligamentum flavum, correction of lysis and facet joint release, and the late effects are atrophy of disc annulus and ligamentum flavum. This is another paper of Hung et al. Where they compare the indirect decompression of MIS-TLIF and OLIF, and they conclude that the indirect decompression of OLIF is superior to that of TLIF. Chang et al. In his meta-analysis concluded that the pain scores, radiological outcomes, and approach-related complications are similar for both TLIF as well as OLIF. This is a case example of L4-L5 lumbar canal stenosis with Shizas grade D, for which L4-L5 OLIF was done. This is a pre-op and follow-up radiograph and X-ray which shows good restoration of disc height, foraminal height, and good remodeling of the spinal canal. To conclude, the indirect decompression effects of OLIF on spinal canal is radiologically superior to that of MIS-TLIF. The time duration and blood loss is less in OLIF in comparison to that of MIS-TLIF. The OLIF procedure restores better sagittal and coronal alignment. The clinical outcomes of both the procedures are same at the end of 1 year. Thank you.